In this video, we're going to talk about allergic rhinitis. Let's start off by defining allergic rhinitis. Allergic rhinitis has been defined as a symptomatic disorder of the nose induced after allergen exposure by an IgE-mediated inflammation. This inflammation in the nasal mucosa commonly causes sneezing, rhinorrhea, nasal itching, and nasal obstruction. Classically, allergic rhinitis has been divided as seasonal allergic rhinitis or perennial allergic rhinitis. However, not every type of allergic rhinitis falls neatly into one of these categories. As a result, today, allergic rhinitis is divided by the intermittent and the persistent types, where persistent is defined as symptoms for 4 days or greater per week for 4 weeks. Allergic rhinitis can further be divided by severity, with moderate or severe disease distinguished by a component of social or occupational impairment. It is important to understand some basic pathogenesis of allergic rhinitis to know how to best manage a patient with this disease, and we'll review this with 5 bullet points. First, the patient encounters an allergen in the nasal mucosa. The body responds by synthesizing and secreting specific Ig antibodies. These antibodies then bind to high-affinity receptors on mast cells and basophils. So this first exposure to allergen is crucial, as it is the first cause of specific Ig antibodies ultimately attaching themselves on the surface of mast cells, which are necessary if any subsequent degranulation is to occur. On the second exposure, the allergen cross-links two IgE antibodies on mast cells. Degranulation, namely of histamine, occurs via calcium-dependent process. This degranulation is the start of the immediate phase of allergic rhinitis. In the immediate phase of allergic rhinitis, preformed histamine release from mast cells is primarily responsible for the symptoms, which peak at about 15 to 30 minutes. They include mucus secretion, nasal congestion from vasodilation properties of histamine, tissue edema, and irritative symptoms like sneezing and itching from the nerve sensitizing properties of histamine. While all this is taking place, in the background, cytokines and other chemical mediators are recruiting inflammatory cells, primarily eosinophils. Eosinophil recruitment and activation is the hallmark of late-phase reaction, which peaks at about 6 to 12 hours. One important chemical mediator are leukotrienes. These begin to form upon mast cell activation. They play a role in recruiting inflammatory cells that are responsible for late-phase symptoms. Late-phase symptoms contribute to the chronicity portion of disease, such as nasal obstruction and decreased smell. Switching gears, we'll talk a little bit about epidemiology. Allergic rhinitis has a large burden on society. Up to 30% of adults and 40% of children suffer from this disease. There's also a significant economical burden on our healthcare system, with approximately $3.4 billion in direct costs and an estimated $11.6 billion in indirect costs attributed to allergic rhinitis. It is important to elicit a thorough history from a patient. A patient may complain of nasal symptoms. Although not mutually exclusive, keep in mind some differences between the more seasonal, intermittent appearing allergic rhinitis with irritated symptoms versus the perennial type of allergic rhinitis with constant exposure to allergen in a patient with obstructive symptoms. A patient, especially with the intermittent seasonal type of allergies, may complain of itchy and watery eyes. A patient may also complain of difficulty hearing due to middle ear effusion, and it goes without saying that it is important to ask about timing and location of symptoms like triggers, changes in living conditions, changes with season that can point towards a diagnosis of allergic rhinitis. It is important to also ask about risk factors. Is there a family history of allergic rhinitis or a childhood history of atopic diseases such as eczema, asthma, food allergies? Ask about associated conditions, as these may be common, such as asthma, sinusitis, etc. On physical exam, look at the eyes. There might be some darkening under the eyes from venodilation, known as allergic shiners, or folds under the eyes, known as Dini-Morgan lines, that may suggest concomitant allergic conjunctivitis. It is important to perform an otoscopic exam as well as tuning fork exams to unmask middle ear disease. In the nose, you might notice some clear rhinorrhea and a bluish gray appearance of the turbinates. You may also notice a transverse crease on the nose from constant wiping, known as the allergic salute. Especially in children with long-standing disease, in the mouth, one might observe a high-arched palate and upper lip elevation. The throat might be red, and there might be some cobblestoning in the posterior pharynx from irritation. And lastly, it is crucial to auscultate for wheezing to screen for possible coexisting asthma. The diagnosis of allergic rhinitis is largely a clinical one. It's based on symptoms, presence of risk factors, and supportive clinical findings. However, there are some adjunctive tests that can be performed to confirm a diagnosis. These tests can be divided into three categories. First, by way of allergen exposure to the nasal mucosa. Second, by way of allergen exposure to the skin. And third, by way of in vitro testing of the patient's serum. In the challenge test, which is not really used anymore, allergen in increasing concentration is introduced to the patient's nasal mucosa, and we observe for the response. In skin testing, the allergen is introduced to the skin in the epidermis or dermis, depending on the technique, and we observe for a response. The response is a wheal on the skin caused by histamine release. Therefore, if a patient takes an antihistamine before the test, we likely will observe a false negative result. This is unlike serum testing, that is not dependent on eliciting a reaction. In serum testing, we detect by means of fluorescence or radiolabeling whether a patient's serum contains specific IgE antibodies to a series of known allergens. Therefore, these tests are not subject to false negatives in a patient who has taken antihistamines. Moreover, as there is no introduction of allergen to the patient's body, there is no risk of anaphylaxis. This is unlike skin testing. However, skin testing is faster, easier to perform, and more sensitive. It is also important to consider a few differential diagnoses. The first are a cluster of syndromes termed non-allergic rhinitis. Perennial symptoms are predominant, and irritative symptoms are rare. A patient might be sensitive to temperature and humidity changes, but specific triggers are often absent, and allergy tests are negative. This is a diagnosis of exclusion. One such disease that falls under the category of non-allergic rhinitis, but that shares many similar features with allergic rhinitis, and therefore can be a source of confusion, is non-allergic rhinitis with eosinophilia syndrome, or NERS for short. Like other non-allergic rhinitis types, perennial symptoms predominate. However, unlike other non-allergic syndromes, irritative symptoms such as sneezing and itching are pretty common. What is more confusing is that a smear of the nasal mucosa will show abundant eosinophils, a feature that is characteristic of the allergic type. However, generally in allergic rhinitis, eosinophils are 25% or greater on nasal smear, whereas they are 10 to 20% in NERS. However, systemic allergies are negative in NERS. And I stress systemic because in 2003, a concept of entropy was formally introduced that may explain the localized hypersensitivity of the nasal mucosa in NERS versus a systemic sensitivity to an allergen in a patient with allergic rhinitis. Moving on, another possible diagnosis may be acute infectious rhinitis. However, this follows a more characteristic prodrome. And finally, chronic rhinosinusitis may be on the differential. However, there are specific criteria to make this diagnosis, which you can pause the video and read. Moving on to the management of allergic rhinitis. Treatment can be divided into four categories. The first, lifestyle modifications, pharmacological, immunological, and surgical. We will discuss all of them separately. If feasible, the first method of management should be lifestyle modification. This includes avoidance of triggers such as dust mites, molds, pollens, or whatever you're allergic to, as well as other techniques that can reduce the amount of airborne allergen, like HEPA filters or high-efficiency particulate air filters that remove, by definition, 99.97% of particles, 0.3 microns in diameter. There are other environmental modifications that can be done to relieve discomfort, like keeping the home humidity between 48 and 52% to avoid nasal dryness. Pharmacological therapies can also aid in the management of patients. I like to group these pharmacological agents by which phase they target. For example, because histamine is the predominant cause of the immediate phase symptoms, antihistamines can be used to provide relief and are particularly helpful for the irritative symptoms in the immediate phase, like sneezing, itching. To target the late phase mediators, a reasonable mechanism of action would be to reduce inflammatory mediators that contribute to the recruitment of inflammatory cells. One such drug are oral anti-leukotrienes that inhibit the synthesis of or block the effects of leukotrienes. Because leukotrienes also increase bronchial tone, they are particularly useful if a patient has coexisting asthma. Finally, if a drug is able to block both the immediate phase and the late phase effects, it would be particularly useful as a prophylactic or maintenance agent. By inhibiting degranulation of mast cells, nasal mast cell stabilizers in effect block the chain of events that lead to early and late phase symptoms, making them useful for prophylaxis. Corticosteroids have numerous effects for symptom relief in allergic rhinitis. They inhibit the production of prostaglandins and leukotrienes. They upregulate alpha-1 receptors in blood vessels, which act to increase vascular tone and decrease permeability, thereby decreasing tissue edema. Moreover, corticosteroids inhibit white blood cell adhesion, as well as histamine release from mast cells. And along with lymphopenia, they cause a decrease in eosinophils and a decrease in the production of interleukin-2. For these reasons, corticosteroids make a great maintenance therapy, and in fact, nasal corticosteroids are the single most effective maintenance therapy for allergic rhinitis. Finally, there are some drugs that do not target early or late phase reactants per se. Decongestants and anticholinergics are two such drugs. The former acts by increasing sympathetic tone, the latter by decreasing parasympathetic tone. An important side effect to note about decongestions, and specifically nasal decongestions, is an entity termed rhinitis medicamentosa, which results in rebound congestion from decreased vascular tone and increased permeability. For the visual learner, this is a schematic of an overview of some drug targets in allergic rhinitis. You can pause the video and look at it if you like. Often there's no single one right answer when choosing a medication to provide symptomatic relief. For instance, a patient with irritative symptoms, perhaps an antihistamine might be suited. If rhinorrhea is the predominant symptom, perhaps a nasal anticholinergic can provide the best relief, though it is more common in the non-allergic rhinitis clinical picture, and so on and so forth. The decision of choosing a medication is best made as a collaborative effort between the physician and patient to best meet the patient's needs. The third method of treatment is immunotherapy, which includes monoclonal anti-IgE antibodies, and desensitization, which involves introducing allergen to the patient in increasing doses over time. There have been several proposed mechanisms that explain why desensitization works. Two such proposed mechanisms are shown here. The first is by continuously increasing the dose of allergen the patient is exposed to. Specific IgG antibodies are formed, and those IgG antibodies act as competitive inhibitors of IgE antibodies that are on mast cells. The second mechanism is that by continuously increasing the dose of allergen the patient is exposed to, the body is exhausted from its specific IgE antibodies. An advantage of desensitization techniques is that it potentially can offer long-term control of disease. The obvious risk of exposing the patient to allergen is the risk of anaphylaxis. There are some contraindications, such as pregnancy, a history of anaphylaxis, and others, but an interesting one to keep in mind is the use of beta blockers, which if taken can increase the effect of an allergic reaction, and this is especially bad if a patient on beta blockers develops anaphylaxis. There are a number of techniques listed here. The allergen can be introduced subcutaneously, sublingually, or intranasally. And finally, although less common, there are surgical treatments available to address allergic rhinitis. One such treatment is radiofrequency ablation of the inferior turbinate. Some research shows decreased nasal resistance and improved congestion when compared to intranasal mometasone spray. Another study found in patients who failed medical therapy, radiofrequency turbinate reduction improved symptoms 1 year out. Other adjunctive procedures can address anatomical abnormalities that can contribute to worsening symptoms in patients with allergic rhinitis. And lastly, like any surgery, careful patient selection is of paramount importance. That's the end of this video. Thank you for watching.